A 2-month-old female brought in to establish primary care presents with tachypnea, difficulty feeding, diaphoresis while feeding, and fatigability while feeding. The mother reports that she has never been cyanotic. She also reports that she takes 45 minutes to finish feeding recently as opposed to the original 10 minutes and feeds every 4 hours instead of every 2 to 3. She sweats when she eats and sometimes dozes off. She burps well after feeds and occasionally spits up, but no vomiting. She has episodes of looking startled, throwing her arms out, tensing up, and taking a gasp of breath. She also reports that the stools have been consistently yellow in color and watery, with 6 wet diapers per day. For past medical history, the patient was born at 38 weeks gestation via vaginal delivery by a midwife in the home without any complications. The patient was born at 2,806.6 grams and 43 centimeters. Immunizations have not yet been initiated. The patient has not had any chronic illnesses or hospitalizations since birth, but has had 1 URI. There are no surgeries, medications, or allergies to report. For social history, there is no tobacco, alcohol, or illicit drug use exposure. For family history, the mother is 44 years of age with diabetes type 2, and the father is 46 years of age with hypertension and obesity. For review of systems, constitutional is negative for lethargy, inconsolable crying, and irritability. Cardiovascular is negative for cyanosis. Respiratory is negative for cough, and all other systems are negative. For physical exam, the vital signs read as temperature 98.5 rectal, heart rate 175 beats per minute, blood pressure 65/50, respiratory rate 58, O2 saturation 98% on room air, height 45.5 centimeters, and weight 8.17 pounds. For general appearance, the patient is awake and alert and coos during exam. For respiratory, the patient is positive for tachypnea. The respirations are mildly labored with accessory muscle use and subdiaphragmatic retractions. The lung fields have scattered crackles bilaterally. For cardiovascular, there is a normal S1 and S2. She is tachy with a regular rhythm. There is a whole systolic murmur heard over the lower left sternal border. There are no lifts, heaves, or thrills on palpation of the precordium. Pulses are 2 out of 4 equal and symmetric throughout. So in summary, this is a 2-month-old female who presents with tachypnea, difficulty feeding, diaphoresis while feeding, and fatigability while feeding. The mother reports that she has never been cyanotic. On exam, the lung fields have scattered crackles bilaterally, and a holosystolic murmur is heard over the lower left sternal border. For assessment, the most likely is either tricuspid atresia with VSD or VSD alone. For tricuspid atresia with VSD, the pertinent positives include exhaustion during feedings, tachypnea, crackles bilaterally due to increased pulmonary blood flow, a holosystolic murmur, a recent respiratory tract infection, and the pertinent negatives include no cyanosis was present at birth and no cyanosis is present currently. For VSD alone, the pertinent positives include holosystolic murmur, heard best over the lower left sternal border, excessive fatigue, rapid shallow breathing, difficulty breathing during feeding. The pertinent negatives include no failure to gain weight. For active alternatives, there is truncus arteriosus and tetralogy of Fallot. For truncus arteriosus, the pertinent positives include tachypnea, feeding difficulties, sweating, easy fatigability, loud hystolic murmur audible at the left lower sternal border. Pertinent negatives include no cyanosis, no failure to gain weight, no mid-diastolic rumble of excess blood flow across the mitral valve, no systolic thrill at the lower left sternal border, and no loud early systolic ejection click. For tetralogy of Fallot, the pertinent positives include dyspnea on exertion, dyspnea during feeding, possible TET spells that occur spontaneously like described by the mother as episodes of looking startled, throwing her arms out, tensing up, and taking a gasp of breath, dyspnea and alterations in consciousness, which is falling asleep during feeding, and a systolic murmur. The pertinent negatives include no sudden cyanosis, which is a big one. The do not miss includes myocarditis. The pertinent positives for this include a history of upper respiratory tract infection, tachypnea, difficulty feeding, tachycardic, and crackles of the lungs bilaterally. The pertinent negatives include no pale gray skin, no S3 or S4 gallop, and the liver is not enlarged or tender. I would like to order a chest x-ray, an ECG, and an echo. For a chest x-ray, this will help us look for tricuspid atresia, so this will see if the main pulmonary artery segment is small or absent, and if the size of the right atrium is moderately to massively enlarged. It will also help with myocarditis, and we will see if there is generalized cardiomegaly present along with pulmonary venous congestion. It will also help us look for tetralogy of Fallot, and we will see a boot-shaped heart. It will also help with truncus arteriosus, and we will see cardiomegaly, absence of the main pulmonary artery segment, and a large aorta that has a right arch 30% of the time. And for ECG, this will help with tricuspid atresia, and we will see P waves that are tall and peaked, indicative of right atrial hypertrophy. It will also help with truncus arteriosus, and we would see right ventricular hypertrophy or combined ventricular hypertrophy. And then for the echo, this will help if there is VSD. It will assess the size and location and right ventricular pressure and function. It will also help if there is tricuspid atresia, and it will show absence of the tricuspid valve, the anatomy of the VSD, presence of an ASD or PFO, and the size of the pulmonary arteries. And overall, the echo is useful for looking at any other additional congenital heart defects. And that is all. Thank you.